Happy Saturday, everyone. We are live on KTOW and we have some really good news. Thanks to KTOW, we are also, and Craig Roberts, we are also going to be live every Sunday at 4 p.m. Well, not live. If you miss it today, you can watch on Sunday at 4 p.m. Eastern Time, the Heart of Innovation. Get ready for a great show. Take it on over, Christy, our producer.
No matter what the markets do. Investments not FDIC insured. Past performance does not guarantee future results. Not an offer to sell or a solicitation to buy any security. Member FINRA SIPC.
KTOW, Palo Alto, Bay Area's business leader at KTOW.biz. On our mobile app, tune in, iHeart, and the Odyssey app. We go where you go. AM 1220 KTOW.
Sponsored by The Way to My Heart Incorporated.
Welcome to the Heart of Innovation, 60 minutes that could save life and limb with new breakthrough ideas and innovation changing the healthcare landscape. Brought to you by Patient Advocacy Group, the Global PAD Association at padhealth.org, in partnership with Reflow Medical, the pulse of medical ingenuity. Here are your hosts for the Heart of Innovation, Emmy Award-winning journalist and founder of the Global PAD Association, Kim McNicholas, and interventional cardiologist and founder of Save My Piggies Health and Wellness, Dr. John Phillips.
For years, patients with a disease more prevalent and deadlier than most cancers combined, known as peripheral artery disease, which is poor circulation in mainly the legs, they've been telling me that they wish that their doctors would understand what it feels like to have this disease and the debilitating nature of it. Well, today you're going to meet someone, a doctor who treats peripheral artery disease, who knows about the debilitating nature of this disease firsthand. And we're going to introduce you to him. It's Dr. Kevin Lurie. But first, we're going to bring in my guest co-host as we await Dr. John Phillips, who is in the middle of a live case sponsored by Abbott. It's called the Endo Masters, and he'll be joining us soon. But please welcome Dr. Amr El Serghany from Hawaii, which is where we all wish we were today. He is also the doctor, the PAD doctor, who is treating the PAD doctor. Welcome, Dr. El Serghany. Thank you so much for pinch hitting today and guest co-hosting.
Well, aloha and welcome, everybody. Good morning. Thank you for having me, Kim. We have some very interesting stories that we'd like to share today.
Oh, yeah, I can't wait. But I think that we need to bring Dr. Kevin Lurie in with a moment of inspiration.
Dr. John Phillips, spectacular vascular moment of inspiration.
We had to bring it in. We got to honor Dr. John. Even though he's not here, he is here. And Dr. Lurie, let's start with some words of wisdom before we get into your story.
Oh, my don't postpone joy. That was on my bumper sticker for many years. And now I live up here in Alaska, and I try to live by that motto of enjoying every day and enjoying the gifts that we have.
Yeah.
And it's beautiful up here, although it's a little cold. It's been snowing all night again. But hopefully I'll be skiing later in the day.
It's no wonder that you chose Dr. El Serghany to treat you, because you had the opportunity to go from Alaska to the beautiful land, the islands of Hawaii.
Absolutely. Yeah, when I was down in Oahu, we had the Kona storms, the hurricanes, but hopefully next time around it'll be beautiful and we'll get more sunshine. Yeah.
Oh my goodness. So Dr. El Serghany, do you want to, kick us off, introduce Dr. Lurie and a little bit of his story and how you two got to meet?
Yeah, so I'm a vascular surgeon in Hawaii, and we have a mission-oriented practice where we go to the different islands, take care of the patients in Big Island and Maui and Oahu. And I met Dr. Lurie through a mutual friend in Alaska. So there's another vascular surgeon all the way up in Fairbanks, where he also practices somewhat remote vascular care with less resources. And he knew Dr. Lurie for several years, so we kind of linked up with Dr. Lurie, and it's been great to have him come over. He's been so kind to come over and help us take care of the patients in Hawaii. So every so often he'll come and do 2 to 4 days, and we load him up with cases. We take care of as many patients as we can. And it kind of gives me a break to go and get the car wash and do the regular day-to-day things, go to the bank.
Wait a minute, you're a doctor and you're human? Wait, what?
Yeah. Every now and then we like to get out and, go surf, actually enjoy Hawaii. But there's a critical shortage of vascular surgeons in Hawaii.
Yeah.
So any help that we can get, and to have such an experienced provider come over and someone compassionate that can work well with the patients and take care of them, and we sort of marry our algorithms so that we can take care of them together. It's been a huge blessing for us.
So, Dr. Lurie, why don't you bring us back to that moment where you first had that conversation with Dr. El Serghany to say, hey, you know what? I not only treat patients, but I am a patient and you're my choice doctor to treat me.
Well, I know a lot of people who do similar procedures, but I don't have a lot of friends that have similar practice styles. One of the wonderful things about working with Dr. El Serghany is that we do have similar practice styles. So I had a particular algorithm that I wanted to be treated with. I knew that I had blocked circulation in both legs. My left was worse than my right, and it was really bothering me, stopping me from my normal outdoor hiking activities and biking and whatnot. So I got an ultrasound up here and I sent it to him and I said, here's my blockage. What's your schedule like? And, when can you accommodate me? And he was really quite flustered. He's really cute and said, oh my gosh, thank you. That's so flattering that you chose me to, have your procedure done rather than somebody else. And so we worked out a schedule. And I think we saw that last program around. I ended up working with him and working all day. And then I was the last case of the day to get my leg fixed. So it's worked out really beautifully.
Dr. El Serghany, was that a surprise when he sent you the ultrasound and you're like, wait, what? You have PAD?
So
And then why me?
One weekend I got a flurry of texts from Dr. Lurie and there's ultrasound results and all those reports. I'm thinking, he's talking about one of the patients, but it turns out he's the patient. And he told me, he's been living with claudication for years. And he's quite the outdoorsman, so he likes to go hiking. In fact, the last time we spoke, he sent me a picture on top of a mountain at nighttime in Alaska. I knew night hiking was a thing. So he's very active. And, he was saying things like, oh, I just want to keep up with the younger guys. I've tried to walk through the pain. He was able to do that for a year or so. And it just got worse and worse and was really holding him up, especially on that left side. So because he had such a good ultrasound report with the images and the findings, we decided that, yes, on his next trip out, he would do the cases. And then on the last day, he stayed NPO. And he basically got out of scrubs and got into a patient uniform. And I came in and did his procedure as the last case after he took care of patients all day. It was quite something to see that.
Yeah, and we're going to get into details, on that a little later on. But you had to have done a double take. What was really going through your mind in that moment when you saw this? And was it a little bit intimidating to think that, oh my goodness, I'm treating patients, but I can actually be treating someone that's going to judge my style and maybe even second guess my thinking or even armchair quarterback while under twilight.
That's interesting. So, well, no, Dr. Lurie, we do have similar styles. So we talked about that. And I saw it as an opportunity to say, hey, like, if a vascular surgeon is a patient, how would he want to be treated? Because there's limits to how much we can agree on. But if he goes through his algorithm and says, this is what I would like to do, and that's exactly what I would have done, this sort of worked out. I've never done vascular surgery on a vascular surgeon before. So that was something. But I saw it as an opportunity to kind of learn something more about what it's like to be a patient from a surgeon's perspective, especially in terms of the recovery and what happens afterwards, comparing the pre and the post.
And coming up next, right here on the Heart of Innovation on KDOW, we're going to hear what it's like from a vascular surgeon's point of view in going from being the surgeon to the patient. That's next, right here on the Heart of Innovation. Don't go away. We can get to, because Douglas brings us in with a really good question just to bring us back to the point where he first was diagnosed. So Dr. El Serghany, normally Dr. John brings us back. I'm going to test your comfort. It's okay if you do or don't, but you can say, welcome back, everyone. Dr. Phillips will join us later. I'm Dr. Amr El Serghany from Hawaii. We're talking to one of my patients and colleagues, Dr. Kevin Lurie. He has PAD. I treated him. We want to get to his story, but to get to his story, we're going to bring in one of the callers. We have a caller, Douglas, who has a question for Dr. Lurie to kick off his story, something like that, or else I can do it either way.
Okay, I can handle that.
I figured. And there's literally, there's no, I mean, it's radio. We're live. It's funny. You can stumble over anything. You could say whatever you want. I always search for the caboose to my train of thought as I'm coming in. Doesn't matter.
Do you find it?
I know. I'm still looking, Dr. Lurie, still looking. I did find another PAD patient who is she's an amputee and is fascinated by glass blowing. Thanks, Christy. And so we want to surprise her at some point with having you as a co-interviewer of her story. So we'll have to set up another interview. I thought it might be really fun for you and fun for her.
1809
Okay, Christy, count Dr. Amr El Serghany down.
AM 1220 KDOW.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kim McNicholas and interventional cardiologist Dr. John Phillips.
Welcome back, everyone. I'm Dr. Amr El Serghany in Hawaii. I'm a vascular surgeon. I took care of a patient who's also a vascular surgeon, Dr. Kevin Lurie, and we're talking to him today about the experience. I'm filling in for co-host Dr. Phillips, and it looks like we have a question from Douglas out there. Dr. Lurie, what point beforehand did you start to think it was PAD? Sometimes we think it's our back, pulled muscles, or working too hard. All the things we think about beforehand, before being diagnosed with peripheral arterial disease, being a PAD doctor.
You know, it's kind of embarrassing to admit that it took quite a long time for me to get there. I'm a little bit older. Yeah, we have back pain. I complained about back pain, and then I took a lot of statins. So I attributed a lot of my discomfort to statins. And then I was visiting my daughter, who's very, very active, and we were on our way to the gym. And there was a lot of walking, and I couldn't keep up with her. And I said, well, this is crazy. How can I not be able to keep up when I'm out all the time? And I would stop and I would window shop because I would start to limp a little bit. And then I was coming back from the gym and I said, well, this is just claudication. This is exactly what I hear about every day. I stop, I pause, I take pictures. And I know when I take out hiking groups, there are places on my little hikes that I stop and say, oh, is that a moose over there? Oh, and look at the sunset. Oh, look at this, look at that. And so I know part of my routine is to stop and pause. But I didn't really understand that part of the reason I was stopping and pausing was because my legs hurt. But when I was with my daughter in November over Thanksgiving, that's when it clicked. I said, oh, that's what this is. And I went back to the office and I said, okay, guys, I need an ultrasound of my legs and let's see if we can figure this out so I can fix it.
So, you know, what's really great about this story is simply that so many of our patients tell us that they were active clear up till the moment they got that first cramp. And I think that breaks the stereotype that this is a disease that is mainly geared towards people who are letting dust gather beneath them, right? People that are living a sedentary lifestyle. And yes, that is a risk factor, and it's a big risk factor. But we're seeing more and more patients in your situation these days who are active. Did this give you a new perspective on the disease and how you address those patients that end up with claudication and they're active?
I think it reassured me. I have a very aggressive interventional style like Dr. El Serghany. And up here in Alaska, I would see lots of patients that my work partners had seen, and they'd say, "Oh, you're not bad enough to get fixed." I remember one wonderful older woman in her 80s who said, "I snowshoe every day, and I can only go out for about half an hour now. And normally I go out for 2 or 3 hours and pack a path for everybody else." And so we got her set up and fixed the blockages in her legs, and she came back the next year and said, "Oh my gosh, this is so great. I've been able to really clear paths for people, and I'm out snowshoeing every day now." This is a common theme here. People can't walk their dogs. People can't get out and do the normal things that they want to do. A lot of people hunt up here. They can't get out and go hunting. So it's very common for people to be limited by their legs, even though they're quite active in their lives.
Oh, that must be so frustrating. Can you actually describe to people what does it feel like to have PAD? What is that cramp like for you? Do you have any analogy, something you would liken it to?
Well, for me individually, I've had a lot of orthopedic injuries to my legs. And so the first thing that happened to me after 2 or 3 minutes is I would start to limp. And I would always attribute it to a bad knee. Say, "Oh, my knee is bothering me again." And so after 2 or 3 or 4 minutes, I would start to limp again. So then I would change my gait a little bit, pick up my legs more with my quadriceps instead of a longer stride. But for me, it presented primarily with knee pain, not calf pain. Yeah.
Well, that's interesting. And then when you would get those cramps, did you get those
Oh,
debilitating
I
Charlie
would get
horses?
I would get them at night. I'd get them if I tried to push through my pain. I remember very clearly I was in New York City one time and I was late catching the train. And so I really tried really, really hard to speed up my gait and get moving down the sidewalk, pulling my bag. And it was just killing me. And I said, "This is crazy. Why should this be killing me?" Well, I guess I did too much. But yeah, we tend to write off our our pain. I tend to write off my pain
Oh, no,
as
you're not
something that's
alone.
just this orthopedic, because I've had so many orthopedic injuries and so many knee injuries that I had no concept that this would be a real problem for me. I've had high cholesterol all my life. I've taken statins for probably 30 years. And I figured that was adequate treatment. I was treated by fancy doctors from Johns Hopkins. That was what they recommended. That's what I took. And I think that's a lot of people's story is they followed all the instructions that their physicians have given them, but nonetheless, there's disease progression. And so they get symptomatic.
Yeah. I mean, it's crazy, but you aren't alone being a vascular surgeon. You're not alone being a patient that continues to brush off those symptoms. So many primary care doctors brush off those symptoms. We interviewed more than 400 patients in our network. More than 70% of them said the first time they presented with textbook claudication, they have hip pain, buttocks pain, even calf pain or behind the knee pain. And the doctors diagnose them first either with diabetes, diabetic neuropathy, it's just your back, it's just your sciatica. Oh my goodness, it's your arthritis, it's gout. I mean, all of these things you might have as well, but we even had a couple people with spinal fusions and even hip replacements where the pain did not go away. And it turns out that those procedures may not have been necessary if only they had gone to a vascular specialist and gotten their blood flow restored, right?
Absolutely. In fact, one of the women that I saw in Hawaii last time around when I was helping out Dr. El Serghany was a woman who had said, "I had my hip replaced and it didn't take care of my pain." And then we opened up her blocked arteries and she said, "Oh my God, I didn't need my hip replaced. That was the problem the whole time." So we certainly see that, and it's frustrating for everybody. You can't really sit there and say, "Oh my gosh, you didn't need your hip replacement," because I don't know whether she did or she didn't. But certainly improving circulation helps people with their pains that have been misdiagnosed. Yes.
And
Yeah.
what would you have to say to your colleague, like Dr. El Serghany or other vascular surgeons out there who say to the patient, "You're just a claudicant, doesn't matter if it's lifestyle limiting, just walk, walk, walk through the pain." and just suck it up, Buttercup.
Well, the insurers now want everybody to be on a walking program for 3 months at least before we do interventions for lifestyle limit claudication. And some people definitely get better. And so I've certainly seen plenty of people in my career who you tell them, if you walk out, halfway to your mailbox every day and push it for 3 or 4 steps every day, you'll be able to walk further. And you certainly see people who have improved and say, oh, you know what? I'm much better. And I don't smoke as much because I'm out going out for a walk and I'm doing better. And that's really helpful for people. And I think it's perfectly reasonable to give walking programs a trial as long as you don't have open wounds and tissue loss. Absolutely.
But it's certainly it's painful. It's not it's not for the faint of heart, because it can be really debilitating and you got to push through. Well, coming up next right here on The Heart of Innovation, more with Dr. Lurie and Dr. El Serghany. That's next right here on KDOW. Don't go away. Awesome. So do you want to get us into deciding that it was time to treat, Dr. El Serghany, and what the days were like for you guys, like how you came up with the plan, what it was like? I mean, you mentioned earlier about the fact that it was very strange to have your colleague do, how many cases did he do that day? 3 or 4 cases. And then to say, okay, dude, it's time, it's your turn. Or him saying it's my turn, and then switching like from the scrubs to a robe, in a sense, a gown, scrubs to a gown, and having to get on the table just where his patient was. So kind of walking us through and painting that whole picture would be great.
Okay, I can talk about the approach as well. And then do you want me to give some details of the disease or what we did?
Yeah,
okay.
Yeah, and how you decided. We have only about 6 minutes in this, so we'll kind of do a part 1, part 2 into the 4th. But remember that these are general people, so you'll have to, any acronyms or anything that you use, just make sure that you're doing a little bit more explaining as if it's a patient that is tuning in as well. Oh, it's Dr. Phillips here.
Hey guys, I apologize profusely. I was doing a live course seminar for Abbott that ran over.
That's okay. Do you want to go ahead and turn your camera sideways for us, though?
Sorry, yeah, I'm actually leaving the hospital. I also forgot that my daughter's confirmation is today. So yeah, we're doing great. But nonetheless, it sounds like this is a good conversation, so I'm happy to listen in.
Okay, so so I'm going to have Dr. El Serghany bring us back, and then Dr. El Serghany, you can say, hey, Dr. John Phillips is back. He's out of the live case. He'll be chiming in from his car, every once in a while. So just maybe Dr. El Serghany, bring us all up to speed, bring, Dr. John up to speed kind of thing, and then lead us into the day of the procedure and stuff.
Okay.
The plan. Boy, this is fun.
Hey, nice to meet you, Dr. El Serghany. Sorry, we're broadcasting to Vegas, so we had to start early, and then they gave us some extra time. So it was good. I'm trying to save some piggies though, Kim. We were saving piggies today.
Oh, I love that. Love saving those piggies.
I know.
So yeah, this will be fun. It'll be interesting. Did you meet Dr. Lurie? Where's Dr. Lurie? Where's Dr. Lurie? Did I lose him?
Here in the top right.
Oh, Dr. Lurie, can you say hello so we see you for a second?
Hi there.
Hi, Dr. Lurie. How are you?
Welcome. Glad your cases went well.
Welcome
Here
back
we go.
to The Heart of Innovation.
Dr. El
For more on
Serghany,
today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kim McNicholas and interventional cardiologist Dr. John Phillips.
Hi, welcome back. I'm Dr. Amr El Serghany in Hawaii, and I'm a vascular surgeon. We're talking to Dr. Kevin Lurie, another vascular surgeon who is a patient of mine. Dr. John Phillips is back as co-host, so he'll be chiming in. And we're going to kind of take it back to the day that we did the procedure and talk about that.
Fantastic. This is kind of exciting. I mean, Dr. Lurie was doing cases. Dr. Lurie, how many cases did you do before the table literally turned on you?
I think we had 3 or 4 people before. I think the practice in Hawaii is quite busy, and because of the nature of what we do, where we see a lot of emergency patients that show up a couple days before, and we try to accommodate everybody. I think we had a couple extra patients on the schedule that day, and the staff actually were quite nervous about the procedure. I think they may have been more nervous than either of us, and they were very curious about their roles and a little embarrassed by everything. But they did a great job, and they were very attentive. So it was a very positive experience. But yes, I had four patients that I did procedures on before my procedure.
Were you anxious at all? Because so many patients, I mean, you had a full schedule ahead of you. You couldn't eat, you couldn't take your regular medications or your supplements before going into your day. You basically had to fast all day and perform at your peak.
Well, not only that, we had the crew there. So there were lots of pictures. There was lots of reminder of what your day is going to be like. It's not like,
Yeah.
Okay, I'm just going to cruise through on autopilot and compartmentalize everything and
No.
forget about it. In fact, we had a lot of very nice people there taking pictures and getting involved and saying, oh, we want to be out of your way. But of course, it's hard to be out of your way when you walk down a hall and the cameras are snapping away. But
So what was going through your mind?
I just get through the day. I have total confidence in Dr. El Serghany. So it was just a matter of getting through the day safely and don't make mistakes. I think it's really important that we hyper focus at times on what we're trying to do and make sure that you don't make mistakes because you let your mind wander.
And so you know that below the knee interventions lead to a revolving door for the most part. And so you've been holding off on having anything done for a long time. What was it that made you say, okay, now's the time. I am ready. I think we've got it. And I think that I can make this last.
I really think part of it is just meeting somebody who had a similar surgical style that I have. Someone who's willing to be aggressive from the very beginning and fix it all at once rather than say, okay, well, I want to fix your inflow disease first, and then we'll fix your tibial vessels, and we want to come from a femoral approach. I didn't want that. I've had complications from that approach before, and so finding somebody who I had total confidence in that could do my procedure in the way that I wanted it done made a huge difference for me, and that's really what got me to move forward.
Yeah, Dr. El Serghany, talk about inflow and outflow and explain what that means. We explain it as, people that turn on the faucet and then they don't fix the plumbing below, and they just hope to God that the body is going to adapt and suddenly out of the blue build these collateral vessels to make up for any blockages in the plumbing and, below the knee, so that there's a place for that extra blood flow that they turned on to go.
Well, that's a very interesting kind of a nuanced point, because that's exactly what the situation was with Dr. Lurie and his anatomy. We I often go from radial approach or retrograde approach, especially when we go to the neighbor island, so we're not accessing a bunch of groins and then getting on a plane.
Right. Going through the arm is radial. Retrograde is coming up from a poke right in the foot or behind the calf and coming up.
Yeah, and sometimes we can do that, and it's a little safer, and it's easier for the patient and easier for us, frankly. So because he had such a good ultrasound, we were able to go ahead with that approach. We went from the left ankle. We sent the wire up, and you know how we get ultrasounds on the patients. There's a catheter, and it's smaller than the size of the tip of a pen. And at the tip of the catheter, there's an ultrasound you can see inside the vessel. We send that all the way up to the aorta and bring it all the way down. So we're imaging the entire length of the left leg to see the level of disease. And the inflow in terms of the arteries above the groin were okay. The groin artery was okay, but the artery in the distal thigh, kind of the lower end of the thigh by the knee, there was a near complete blockage.
Oh, wow.
That outflows, usually everybody has 3 vessels below their knee. And we say you only need one good one unless you have a terrible amount of pain or a wound that doesn't want to heal or tissue loss like gangrene. The issue is oftentimes where those arteries divide, there's a blockage. And if you don't have good collaterals and you don't treat that blockage, even if you treat the disease around the knee, and if it has nowhere to outflow, the result's not always as durable, and it doesn't necessarily treat the problem in terms of where you're trying to treat for where the pain is. So he had a situation where the tibioperoneal trunk artery, it's a small artery that divides into 2 below the knee, and it supplies the outflow for the blockages in the arteries at the knee level.
Mm-hmm.
That artery was fairly diseased. We generally try not to stent that area. So we get through, and it's okay to put a short stent somewhere above in the bigger arteries. It's more durable. But we generally try to avoid stenting that area unless somebody is facing limb loss, and it's the right thing to do. So we use the device called a spur. It's a stent that we place inside the artery that's retrievable. So you deploy the stent. It has these filaments on the outside that engage the plaque. And the way they create an organized restructuring of the plaque and create a lumen, when we take the balloon down, the stent comes with it, and we remove the stent completely from the body. So it's a temporary, sort of like a temporary stent that goes in for about a minute or 2. It creates a lumen, and because it creates it in such an organized fashion in terms of how it expands the lumen in the vessel, when we take it out, we often don't have to put a stent because the result is good enough that we have good flow.
And coming up next right here on the Heart of Innovation, we're going to find out how he did after the first leg was done. That's next right here on the Heart of Innovation on KDOW. Don't go away. Awesome. Sorry, I had to cut you off. He said coming up next. I don't know if Dr. John's still here.
Yep, I'm listening in.
Well, do you want to bring us back to this one and say your understanding and get a question in?
Actually, yeah, let me just hold on. I'm getting a call from the folks at Abbott. Give me 2 seconds.
Okay. Well, it's fine either way. Because if not, we want to get into
we're still live on the breaks.
We're still live on the breaks, yeah.
Okay. Cool.
I think our good friend Karen, hi Karen. I can say hello to her. And then if I hear my dad behind me with the show going on, he listens on his radio.
So cute. Your best fan.
Yeah, it's kind of fun. So how do we, I don't know if he's gonna want to start, or should we just, Dr. El Serghany, you want to?
Yeah, did you want to keep talking about that, or do you want to talk about something else?
Yeah, no, I think everyone would be interested. I'm fascinated by how the procedure goes, what your thinking is, and then maybe Dr. Lurie to jump in and comment on, you're hearing what was going on in your arteries, you're hearing what he's doing, as part of this. And then we'll go into the other leg, what you're able to do, what you're able to do now versus what you weren't able to do. The fact that he sent you a picture at night, the top of a mountain would be great. And we have to mention his glass blowing at some time. Because I would imagine that you're on your feet a lot when you're doing your glass blowing. I watched those people when I was at Murano Island a couple weeks ago.
Can you see what I'm trying to show you here? Let's see that.
Oh, put it in front of you.
In front of me.
All the way. There you go. All the way in front of your face. There. Oh, look how pretty that is. Oh my God, that's gorgeous. My favorite color.
It's Mother's Day. You got to make pink glass for Mother's Day.
Yeah, you do. Those are beautiful.
Hey, Kim,
Wow.
sorry. I'm back. Sorry about that.
Okay. So do you want to take us back in, thank Dr. El Serghany, and ask a question of either Dr. El Serghany
Yeah,
or
I mean,
Dr.
I'd love to ask you guys, like, it's hard
Yeah.
enough doing a case on someone you don't know, let alone a colleague. And, I think, at least in my experience, sometimes those of us that are doing the procedure tend to overthink it a little bit. And there's like the quote VIP, well, I've just seen enough VIPs have complications because we try to do too much. So I'd love to, if you guys are comfortable with it, I'd love to kind of talk about that if that's appropriate, because I think that's something that always goes through my mind.
Yes.
And I remember DeBakey saying one time, like, you know what, everybody's aorta looks the same, or something along those lines.
Yeah. So yeah, that'd be great if Dr. John just we did explain in the beginning that you were we gave Abbott a little bit of a shout out and
Oh,
said
thanks.
but you actually missed our news at the beginning. So we had exciting news for the show that KDOW and Craig Roberts, who's the head of operations, let me know yesterday that our show has another time slot. So they're granting us, not only we're airing Saturday live, but on KDOW, but on Sundays, we're now going to be airing on KTRB, their sister station, at 4 p.m. Pacific time. So for people who miss it here, so we get 2 runs over the weekend with the Heart of Innovation. So big thank you to Reflow Medical for sponsoring it, giving us this opportunity, and then
30
Craig Roberts and
seconds.
team. So
100%. Congratulations. Well done.
yeah, well, for us, I mean, it's
Heck
great.
yeah. That's awesome. Howard Stern move over.
I know, right?
Is he still on?
I don't even know. It's the #1 healthcare innovation radio show in the Bay Area. So, okay, so Dr. John is going to take this one away.
This is SRN News.
AM 1220 KDOW.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kim McNicholas and interventional cardiologist Dr. John Phillips.
Welcome back, everybody. Thanks for joining us. Again, apologize for missing several segments, but as I was kind of listening in, wanted to ask you guys, to do the case itself is difficult. To do it on a contemporary, I think, is even more difficult. Can you walk us through, like, mentally how you prepared for it? Because oftentimes we overthink these, and folks that get treated, kind of the VIP status, I find like we do too much to them sometimes, and you just got to keep it simple. So was that, any of those issues going through your head, or just kind of like, hey, it's an artery, we got to get it opened and let's go?
Yeah, I mean, when I first got when Dr. Lurie first reached out and said he wanted me to do the procedure, my first thought was, wow, what a privilege. Second thought was, wow, what if something goes wrong? I mean, it's rare.
Right.
Yeah, right, exactly.
It's and he's a surgeon as well, so it's something to consider. But when I looked at the anatomy, and I think for the most part, I just said, you got to treat this like any other patient. You do this every day. And Dr. Lurie actually made me feel comfortable. The fact that he chose me and he had confidence, I kind of built off of that confidence. So I mean, it was a colorful day. I can't stress enough, with the staff and everything. We try to just keep everything even tempered and do what we usually do. We have an incredible staff, and they're so professional. They're so good at what they do. So I feel comfortable in that room. And after talking through the treatment plan with Dr. Lurie, and we both agreed exactly what needed to be done, we felt okay about going ahead.
What was it like for you, Doctor?
And if I could ask a follow-up, Dr. Lurie. Yeah, I was just going to say, like, were you making suggestions, or did you just like be a good patient and be quiet?
Go to sleep.
Oh, I don't think I was quiet. I think I was more curious than anything else, because we do all these procedures, and some people complain of pain, some people complain of discomfort, some people complain of all these different symptoms. And so I was really curious, what does it feel like, right? What do you actually feel when you're having a procedure done? And so for me, and from a technical point of view, the only challenging piece in the procedure is getting access to the vessel. And I've seen Dr. El Serghany get access instantly in everybody. So I had no worries about that. But I was wondering, what do the balloons feel like? What does the spur stent feel like when it opens and closes? I think we did CSI. What does CSI feel like when the thing spins around? What do you actually feel?
Yeah, that's the rotating sander, right? To break down some plaque.
To core out the calcified plaque. So I was curious about what that felt like. And one of my friends was there keeping me company. So she could tell me, oh yeah, this is what they're doing and this is what's going on. And so I was able to kind of say, what is that? And it doesn't really hurt so much as you feel vibrations, or you feel things opening and closing, and you feel procedural pieces. And so I was really curious about how things felt.
Yeah, what did it feel like to have that balloon? That's the one thing I always hear. And sometimes you hear the patient groan when it's cracking that plaque as it's dilating, right?
I'm not particularly pain sensitive, so it wasn't painful. You could feel things moving in there. And I think if you don't understand what's going on, you may perceive that as pain. I just really felt that as sensations that I've never felt in my body before. And so my body didn't know how to identify what those feelings are. And so we put a pain label on it. But in fact, they're just weird pressure sensations and weird stuff, like things are inside of your leg moving around, but you don't know what they are.
And experiencing how has it changed the conversation with your patients on it? We have 30 seconds.
I just tell people if they're feeling things that actually hurt, then I can give them pain medicine for the hurt. If they're just feeling weird feelings, I tell them, the balloon's going to be up for a minute, and I'll count down with them that minute. And if it doesn't bother you that much, just bear with me for a minute. And when the minute's up, the discomfort will go away.
I just would imagine their trust for you now doing the procedure is even so much greater because you've experienced it yourself and you can talk from personal experience.
That may be, yes.
And coming up next right here on The Heart of Innovation, we're going to hear final thoughts. We're going to hear he did have his other leg done and how he's able to live his life to the fullest now with so much joy. That's next right here on KDOW in The Heart of Innovation. Don't go away. Sorry, Dr. John. I'll let you get in on this one.
So actually, Kim, we didn't do my other leg. I got so much better. I got so much better that I couldn't bring on enough pain to justify fixing it. I've been so good. It's like, okay, yeah, I can make it hurt. But if somebody came to me and said, oh yeah, 10 minutes, your leg hurts, it's just not bad enough. On the bad side, now that I can do more, my heart's ischemic and I have to get my heart fixed.
Oh, shit. See, this is such an important point because we have so many vascular surgeons that tell us that, oh, well, we don't even bother to check the heart until they actually have symptoms. And I'm always like, no, as soon as you get the legs fixed and you take, right?
I think it's under recognized and treated. I mean, at least 20%, if not more, of patients with PAD have underlying coronary artery disease. And I will tell you this, I have had a little pushback because I've started stressing most of my patients, and you got to tweak the note a little bit to get insurance to cover it. And I've had some deny it, but nonetheless, I mean, it's an important point we should talk about.
Yeah, and guess what? This is the shortest final segment ever. This is 3 minutes 40 seconds. So I think we got to get to all that,
That's
Dr.
an
John.
important. It's an important point. Yeah.
Yeah. And we also have to get to all of the things he's doing now. And we could just continue for a few minutes after the main show is over, and I could always
See, I
edit
bought this
more
one
in.
for you that I made the other day.
Oh, that is so cool. Annie is into glass blowing, Dr. John.
Oh,
It's
really?
just amazing.
Like,
yeah.
There's the Aurora.
Chihuly, right?
There's the Aurora right there.
Yeah, that's awesome.
Wow, so beautiful. So 3 minutes, 40 seconds, hard out. I know. But you guys, we can literally sound for a few minutes afterwards, and then I can edit that into the main video show later. But we got to end clean on the radio portion of this. So that's important. So we need to address, Dr. John, are you going to take us back on this one?
Yep. We're going to go right to the CAD portion of it.
Yeah, and that he didn't have. That's his right in the middle of his.
Yeah, that's of course right there. But he wants to, but that they were going to do the other leg, and Dr. El Serghany did such a great job on the one leg. He didn't need to do the other leg. But, and then there's a but, ... It'd be great for a quick getting Dr. El Serghany surprised that he didn't have to do the other leg. Just how good of a job he did on the one.
Yeah.
And then
I want to figure out a way to get to practicing in Hawaii. That's the most important thing for me here. I love.
Come help us out.
That's awesome.
Bureaucratic sludge. The answer. There's so much bureaucracy. It's unbelievable.
Yeah.
My older brother's an interventional cardiologist. He helps us in the lab.
Does he? Yeah. But now you mentioned, and I'd love to learn more about it, but so you go from island to island, right? So that's kind of crazy too, because you do the case and then fly back to your main island. So you're right. You are literally off the grid for that patient.
Our PAs and NPs are incredible. And then there's a lot of coordinating care. Like I'll call the ER before the patient gets there because I already know what's going on. But we'll call our office first. So that part's challenging. One of our nurse practitioners is writing a thesis on it, how we've been able to do remote vascular care.
But so you're not like when you are asked to go to another island, that's planned, right? I mean, it's not like
30 seconds.
Every Monday, Tuesday, I'm either in Kona or in Maui, alternate.
Okay.
Facilities there. Yeah.
Awesome.
We're going to get him kiteboarding in Maui, though.
Yes.
Excited about that.
I'll
send you a video.
Have they, was it Lanaya or the place that burned? Is that?
Yeah. I mean, you hear patient stories from the patients, though.
1220 KDOW.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kim McNicholas and interventional cardiologist Dr. John Phillips.
Thanks, everybody, for joining us. We've got less than 4 minutes in our final segment. So, Dr. Lurie, let's get right into it. The one leg was fixed up. You're feeling great. It sounds like you had some disease in the other, and they were contemplating fixing it, but you felt pretty good. Didn't need any procedure, which is great, right? But it sounds like the heart started acting up. Can you share a little bit of that insight with us, please?
Well, I've had a great result from having my leg angioplasty done. Immediately, I could walk much better. And I quickly realized that I was pausing in places that I didn't need to pause anymore. I would go and say, oh, look at this view. Oh, no, keep going. Keep going. You don't need to stop here. And I'd push myself through. And I hike a lot, and I'm quite busy. So I tried to find places that my right leg would start to hurt after my left leg got improved. And it was hard. It's hard to bring on symptoms on my right leg. So I went to the gym and I went on the treadmill and said, okay, how hard do I have to push to get my right leg to hurt? And after about 5 or 6 minutes at like 33 degrees or whatever the incline is, my right leg would start to hurt. And I'd say, okay, I have enough. And one day I was on the treadmill. I said, I haven't had a stress test in a while. I should go get my stress test done because now I can do more. So I called up my cardiology people and I said, let's have a visit. And I went in and they looked at me and said, oh, yeah, you need a stress test. So I got a stress test. And, since I'm well versed in everything that's going on in these procedures, now I could walk a lot further on the stress test and stress echo. So I'm doing my stress echo and I do my resting. It's fine. And then watching as the EKG changes and I go up to a heart rate of 20% above predicted, which is 152. And I can watch the EKG changes, my inferior leads drop out on the computer screen. And the cardiologist
real quick, sorry, were you having symptoms?
No.
Okay.
I was still talking. And the cardiologist started to just babble about stuff. Oh, you've got inferior this, and you've got this and that. And the staff was really uncomfortable. And they go back to the ultrasound, and I knew this ultrasound tech, and when she's uncomfortable, she pushes really, really hard on my chest wall to make sure she gets good images. And she was just crushing my chest wall. I said, Carrie, what are you looking at? She said, oh, I can't tell you. So
that's the worst.
So then when we got the result finally read, I have inferior changes in the heart muscles down at the bottom and on the sides, which corresponds to previous heart blockages that I've had. So in the next few weeks, I'll go ahead and get that fixed by another friend of mine in Washington, D.C., Nelson Bernardo, who's a phenomenal.
Oh my gosh, are you kidding? Nelson Bernardo. That is
He's
amazing.
my man. He's my guy.
He's our go-to for so many of our patients, both legs and the heart. That's fantastic. Well, thank you so much. But you're doing great. We can't wait to have you back on an update. And Dr. El Serghany, great job getting him back on his feet. Thank you so much.
Yeah, what a win. And then now we get to check his heart. That's awesome.
Keep me alive so I can keep working for you in Hawaii.
Exactly.
I love it. We're continuing the conversation at youtube.com
Great job, guys.
@ the way to my heart. So join us there.
And interventional cardiologist.
Okay, welcome to the after show with Dr. Kevin Lurie and Dr. Amr El Serghany. Also, Dr. John Phillips is here joining us literally directly out of a live case it's an educational seminar that he performed, sponsored by Abbott. It's called the Endomasters, I believe. So he's here as well. We were just talking about in the main show that you can go to youtube.com / the way to my heart, go under the live section. You'll see the full broadcast where we're talking to Dr. Lurie about being a pad doctor who has PAD, and he got treated by Dr. El Serghany in Hawaii, of all places. Let's all go to Hawaii and let's overbook, right? Dr. El Serghany's already overbooked schedule because he's in a remote area. And Dr. El Serghany, you go island hopping on a weekly basis to treat patients.
Yeah, that's part of our mission out here. When I came to Hawaii, it had been about 15 years since a vascular surgeon had come to Hawaii. So we brought some newer approaches and techniques. And at the time, Hawaii was swamped with dialysis patients. The vascular surgeons take care of as well. So we had some of the highest amputation rates in the country.
Oh my gosh. That's incredible. I hear you're a nurse practitioner that was working on a thesis, right? To show exactly how to do it, because we have areas like this across the country. And you could help lead the way in how to do it right.
Well, yeah, there are lots of areas around the country. We call them vascular deserts, so to speak, where there's a high level of disease, where we see this problem. Not enough people that treat it, vascular surgeons, interventional radiologists, interventional cardiologists. It's kind of all hands on deck at this point to take care of these patients.
I mean, Dr. Lurie is also very experienced in those remote locations, right? Dr. Lurie in Alaska. That's why you went to Hawaii.
Well, that's correct. I describe the hospital that I work at as if the earth was flat, we're the last hospital before the earth falls off. We're pretty far off. It's like the TV shows that one would watch about remote Alaska.
Is it near Anchorage? Are you near Anchorage?
About 50 miles north of Anchorage, yeah.
Oh wow. Oh,
and so the next hospital up from us is 330 miles away. So it's it's pretty much the edge of the wilderness.
And so for these patients that are actually in Anchorage that you're treating, you can't wait until they are in critical limb ischemia, but you do end up with most patients that don't come till they're in critical limb ischemia. I mean, these people need to, it's a fight for survival up there. They need to move.
That's right. We have lots of beautiful stories about people who are way out in the bush, often don't have normal utilities. They're called dry cabins. They don't have water or electricity.
Wow.
They're off the grid, and they'll tell stories about, oh, my toes were turning black, and I thought it was because the fire was too hot. Well, no, it's not the fire is too hot. It's that you have no circulation, and you're putting your feet right on the edge of your Franklin stove to keep them warm. And it's a pretty common story, and we're able to salvage a lot of those through aggressive limb salvage techniques.
And Douglas wants to
get
jump
them
in.
back to their lives. Yeah.
Douglas, go ahead. You have a question for both doctors.
Yeah, amazing story. Thank you for sharing with us. That's awesome. How has this impacted your outlook as a PA doctor in dealing with your patients today? I imagine you were great doctors before, but now with this experience, how has that changed that outlook when you're dealing with patients today?
Well, I mean, what the big thing for me was getting the phone call a few days later, and Dr. Lurie's like, I just can't bring on the pain. He's out there running around doing everything he likes to do, and you can hear the excitement in his voice. And getting that feedback from a patient who's a friend, that was everything to me, because that's really what, I mean, the heart of what we do is to get people moving again. And just, it's such a great example, because if he hadn't started becoming active again after treating his leg, he wouldn't have brought about, the chest issue. And that's where patients can kind of steadily decline. And it's sort of an insidious process where they're just not walking as much, and there are all kinds of reasons for that. But maybe it's if the legs are holding you up, you don't get to challenge the rest of your body. So your overall health can slowly decline. That's kind of the hidden danger. In Hawaii, we have so many patients. Yeah, I got patients in their 80s, and they still play tennis, golf, they're out and about. Mm-hmm. So quality of life is still a key factor. So it just kind of reassured me that we're doing the right thing. We got to keep treating these people and getting them out there to enjoy being mobile and active.
And Dr. Lurie?
Yeah, I echo that approach. I think just being more aggressive in terms of getting people back to their life and lifestyle is really wonderful. I'm doing more pedal approach since I started working with Dr. El Serghany. I think it's a nicer approach. I think it's easier on the body, and the recovery is much faster.
Does that answer your question, Douglas? So, Dr. Lurie, just for those that may have never had a procedure before, describe what the experience is like. I know you touched on it during the episode, but just walk us through, what are the feelings? What are the sensations? What is it like from a patient's perspective versus the surgeon's perspective?
The procedure itself, there's a lot of waiting. There's a lot of expectation. And it's not like you're waiting for a plane. You're sitting there waiting, kind of like, what's going to happen here? And how is all this going to unfold? And it's all going to unfold, like the plane is going to take off. But because it's way more personal, it's more intense. And then there's a lot of people fussing over you. Most older men aren't used to a bunch of people fussing around you all the time. Never mind beautiful young women. And so they're fussing with your arms, and they're putting stuff on your legs, and they're shaving you, and they're changing your clothes. And you're like, well, this is nice, but this is weird, and then for the procedure itself, you have some sedation, which clearly takes the edge off your anxiety. And so for me, the anxiety then just washed away, and it's a little uncomfortable, and you hear the discussion going on, and then you just hear people working, or you hear the radio, or you hear this chit chat that has nothing to do with in general with the procedure itself. The feelings that you have, that I perceived, were feelings that I have no words to identify. They're movement inside your body. I remember saying to the person who was with me, "What are they doing?" Well, as the spur got reclosed, you can feel
the retractable stent. Mm-hmm.
Yeah, the retractable stent. So the retractable stent is a phenomenal concept because the stent goes up, but the balloon goes down. So the blood is flowing down your leg while the stent is up, and it stays up for quite a long time. And then when it's retracted, you can feel the spines going back in. You see, in the procedures that I normally do, there's nothing that goes boom, 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 and you feel that boom, 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 boom going in your leg, and you go, "What is that? That's really weird." The CSI, the rotational device that cores out the blood vessel, I didn't feel that at all, but it is quite noisy. And so that's a little unnerving, but once you understand what it is, it's not bad. And then there's a lot of, from doc, there's a lot of apology. I'm going to hurt you, this is going to sting, this is going to burn, this is going to be, and that's all normal stuff that we say, but it's true. There is some discomfort, but we have blood drawn all the time and we learn to live with it. I don't think it's much worse than that.
Yeah, and we didn't have you sedated all the way, Dr. Lurie, because we knew, like, you kind of wanted to know what was going on. So we got you comfortable, but some patients don't, won't experience as much of that stuff. I know when I had my clavicle, I broke my clavicle when I was in residency, and I could hear them say before the procedure, "Oh, he's a doctor, give him extra stuff." So they didn't want me to experience anything. But that was not really our style for doing a peripheral angiogram, where you kind of already know what's going on. And we wanted you awake enough because at the end of the procedure, it was kind of fun when I was like, "Oh, I've never seen that before."
Right. So then we had to go through the images. I said, "Okay, now show me the images. Show me this. Show me what we did. Talk me through this. What were you thinking? What was that?"
Yeah, that was sort of the fun part for us. Yeah, it was such a fun day.
Yeah, while he was laying there, you were able to go through the results. But could you see, Dr. Lurie, could you see? I know when my dad was in his heart procedure, he's an engineer, like captain in the Navy. He loves knowing everything that's going on, and he has a very high pain tolerance, so nothing bothers him. He wanted to watch the whole thing, so they put a monitor there so he could watch, and they talked him through the whole thing. Was that the dynamic that was happening during this procedure? Dr. El Serghany, were you literally walking him through what you were doing?
Yeah, I wanted him to see the screen, but I didn't want him to see too much. You know what I mean?
Yeah.
Once there's the key moment in the procedure when you get across the lesion, and pretty much that's 80% of the kind of the work or the challenge. So a lot of times we'll tell patients that, they're curious what's going on. Well, we got across a blockage. That's great news. It means we probably don't have to do a bypass surgery. This is going to work. And then you just go through the rest of the process and get the procedure done. So definitely those key steps, we let him know what's going on. And then in between that, he was asking, the nurse, "Hey, what can you see on the screen? What are they doing there?" So we kind of kept an open line there.
Was there ever a moment where you got a little bit nervous, in terms, because with him talking, you're not used to having a patient talking to the nurse about everything that's going on, and then hearing almost an echo to what you're doing from the nurse.
I kind of liked it because, I respect Dr. Lurie a lot in his opinion. So I wanted to engage in what was going on, just in case there was something where, maybe he'd say, "Wait, don't do it that way," or something like that. I mean, that never happened, but I just wanted that kind of open so that, he could feel like he was engaged too.
That's certainly true, Kim. When I had my Dr. Nelson Bernardo did my first heart stents, and I did have a screen. I was very lightly sedated. And we did have that ongoing discussion about, do you want me to use shockwave here? We have a 90% circ lesion. We can do this, but we can do that. And he and I had that discussion. It's interesting, at Washington Hospital Center, they have strict limits on how much sedation you can get depending on your age. And since I'm a little bit older, they said, "Oh, we can't give you more sedation. You just have to stay awake."
Which worked out well, though, for you, because you got to.
I'm here and talking about it. It's good for me. Yeah.
Yeah, definitely. And I know Heinz, go ahead and unmute. You just wanted to comment in on just being in La La Land versus Twilight. And I know they talked a little bit about that, but maybe you have some additional questions as well.
No additional questions. All I remember is I don't remember. That's the thing. And then I wake up and I said, well, how far along are we? And we're done, and I've had it a few times. So every time I was out, I didn't feel a thing. Maybe that's good.
I always tell patients that it's good to a point. You don't want to be, I know a lot of patients don't have a very good pain tolerance. And I know sometimes when the balloons go up, you do hear a, ooh, from the patient, but that's a good sign for the doctor. Can you talk about that feedback and how important it is during these types of procedures?
I personally ask patients if they want to be more asleep or more awake. And since I'm like to be more awake, I give people that option. But also up here, I love to hear people's stories. So I just want to hear the stories of their lives very often. And as long as I know that they're able to talk and even if they're prattling on about their grandchildren, I know that they're okay. So I personally like them a little bit more awake. But if somebody wants to have deeper sedation, it's perfectly fine. And as long as they're comfortable and safe, that's the important thing.
Dr. El Serghany.
Yeah, I think I take a similar approach. We look at their profile and decide what would be a safe amount going in. And some patients are more anxious than others. Some people that have had it before, and this is a minor thing relative to what they've been through. And it's also nice to hear their stories. So that's part of it. Yeah, but a lot of patients they go to sleep and they're sleeping and they wake up and the work is done and they're surprised, feel like a short time. But then sometimes you get patients you can hear them snoring and they wake up at the end of the procedure and say, I was awake the whole time. So it varies. It really does vary.
Yet they really were not. Yeah. It's always so cute when you hear them snoring, like they won't remember a thing. And they'll have warm toes when they wake up. They go to sleep with cold toes and they wake up with warm toes, did you notice a difference, Dr. Lurie, with the temperature of your foot before and after? Could you feel it right away?
Not only the temperature, the color. Yeah, I remember I was in the recovery room. I said, take a picture of my feet. Look at that. My left foot is so much shrinking than my right foot. That's fantastic.
That's awesome. We have Alan. Alan wants to jump in with a question. Alan, go ahead.
Hi, thank you. Doctors, I heard that, like what I've listened to, you discovered you had PAD, you had a procedure done and your pain went away. And I've had PAD for 2.5 years, and I have pain when I walk. If I walk at a slow pace, I don't have very much pain, but if I walk at a fast pace, I end up with a lot of pain. And I've avoided talking with my vascular surgeon about a procedure because I've always said, as long as I can keep walking, even if I'm in pain, I shouldn't avoid getting a procedure. I'd like to hear your viewpoint on that.
Well, we call that lifestyle limiting claudication. And for me, personally, it really impacted the amount of activity that I can do. And I wanted to be able to do more. I'm 69 years old, and my mom is 102, so I have big expectations of being around, and I want to be able to do more things. And so I couldn't. So I asked Dr. El Serghany to fix that so I can be more active. And I'm a lot more active now, and additionally, I can go faster and don't have as much discomfort when I do things.
Okay.
Yeah, the whole key is being active, right?
So I think that for me, if you came into my practice and said that, I'd say, well, if it depends, it's your choice. You're not going to lose. It doesn't sound like you're going to lose your limbs. If you've done lifestyle modification in terms of stopping smoking, control your diabetes, control your cholesterol, whatever it is that's causing your problems, and you're still having problems, then talk to somebody who's experienced, who has a really modern approach to fixing these, and see if you can get better. Because there's a lot of people who don't have a lot of vascular surgeons, a lot of interventional cardiologists don't have this skill set. This is a specialized skill set beyond the normal skill set. And if you go to, don't know where you live, but if you go to a place that has people who can do a high-end approach, then it's worthwhile, I think, and gets you to do more. And if you do more and you move around more, you're happier and healthier.
Do you feel like there's because where Alan's located in Canada, and we find, you know, there are a lot of spots in Europe and Australia and just other places in the world, but unfortunately, even in the US, there's still a large contingency of doctors who say you don't treat below the knee. And if you do treat below the knee, and a doctor does do it, it should only be when you have a wound that is not healing and you have continuous or consistent rest pain that is waking you up at night. But as I said, there are doctors that still will say, walk, walk, walk until you can't walk anymore, and then we'll just take your leg. And I just heard 2 more of those, unfortunately, just this past week. It's still happening. Do you face any sort of backlash from those doctors who still rely upon 2013 data that says it's not worth treating below the knee?
I get a lot of pushback in my previous practices for that. Yeah. And they were not particularly older doctors. They just don't feel that that's the right approach because they don't have enough experience. In my view, they don't have enough experience and great outcomes to know that people do much better with a more aggressive approach.
And Dr. El Serghany?
Yeah, I mean,
I know I'm putting you on the spot here. I know it's
a
very
good question.
contentious.
It's definitely relevant. It comes down to the art of medicine, and you know, I look at the anatomy and I try to put that together with the patient's symptoms as best I can. And you know, even in Hawaii, with the limb salvage crisis when we first came here several years ago, people weren't treating arteries below the knee, even for wounds or gangrene. And I always pointed to a few different reasons for that. One is they just didn't believe in it, whether it was the data or they tried it and they didn't see durable enough results, or they don't do it a lot, so they don't believe in that approach. Another advent was the IVUS, intravascular ultrasound on the tip of a catheter. You can see inside the vessel, so you can get a really keen look at what's going on. And when you do a tibial intervention, and with also some of these devices where you prep the vessel before you just balloon it, it makes a difference. So this is a nuanced thing, but if someone goes in and you balloon a tibial artery that's calcified, probably get narrow again in 3 to 6 weeks. That's not enough time for a wound to heal. But if you prep it with a device using intravascular ultrasound, and it's, you know, you're almost obsessing over this part of the procedure, and you get a nice result, that could stay open for 6 months. That's enough time for the wound to heal. And then when that artery shuts down again, the wound's already healed, you built collaterals, you've gotten out of trouble, and it was worth doing it. The leg stays on. So, but if you don't take that approach, or if you do it every now and then, number one, it's difficult. It's definitely challenging, requires a level of skill, and that comes with doing volume. Number two is it's risky. It can be risky if you don't do it a lot. So if you're not comfortable with it and you go in, you have problems, you might be less likely to go and try that approach because maybe you made the leg worse. Number three is, like I was saying, the people, if they don't believe in it, that's just a matter of being up to date on the literature. And unfortunately, a lot of times what we do is we base it on our anecdotal experience. So if we have a case where something worked really well, we subconsciously kind of lean that way. If something didn't work, we try to avoid it. But we should practice evidence-based medicine. So the literature supports that approach now. But I think because the literature hadn't caught up years back, people that tried the approach and for all those other reasons didn't go well enough. They just don't believe in it. And it's unfortunate because you can't always do a bypass. So they would say, okay, well, let's just go grab a vein, do a bypass down to the foot. But that's not always an option in elderly patients, frail patients. The anatomy, the artery is too small and calcified to go and sew a distal bypass into. So sometimes your only good option.
And what I don't understand is, I mean, why are doctors? I just had a doctor tell me, I had a patient who's 85 years old, And based on a CTA, and then ultimately they did do a diagnostic angiogram, but they didn't send an IVUS for it. I said to the doctor, I said, she's 85 years old. She has BTK disease. No one's ever tried to take a wire and balloon down there. Why are you even contemplating bypass, even going in with, at the very least, IVUS to double check things? Oh, you don't know what you're talking about. You're not a doctor. I mean, I've only observed thousands of hours of procedures across the globe, but I know nothing. And it was great because the patient got transferred. And the other doctor was like, oh, of course, same vascular surgeon title, was like, no. You never do a bypass unless you at least go in with IVUS first. You need to make sure the outflow is even good. So you need, and you can't tell from a 2D image what that's going to look like, in her opinion. But I've heard it from a lot of top surgeons, including you, Dr. El Serghany, right? You like to go in and see for yourself first.
Yeah, well, kind of a nuance point there is, the aorta comes down, splits into two, one for each leg. You get these big iliac arteries that supply that third of the body, more or less. And when you inject contrast and the blood rushes quickly through that area, sometimes you see some haziness. It's very easy to miss iliac disease, like disease in those big arteries. And that's the inflow to the entire leg. And when you use IVUS, it's shocking. I mean, I'll take an angiogram, I'll see, I'm like, oh, I don't know, maybe there's a narrowing there, it looks mild. I'll put an IVUS in, it's like an 80% blockage. Because the way the plaque is shaped, if you're seeing this, it looks like a wide lumen. This is kind of a 2D image where, you see like a wide channel. But then on IVUS, you go look, and it's because there's like a crescent-shaped lumen that looks like it's wide, but if you don't get a bunch of different angles with the C-arm, you're not going to notice it. So the IVUS really helps us be more deliberate and get really what's going on in the vessel. And the reason that's important is because if you miss iliac disease, the patient can have pain still, and it's not enough to maybe go treat the distal disease, or you don't want to treat the distal disease, the disease in the thigh or the knee, because once you start treating there, it sort of starts the clock, and you have to, every 6 months to 2 years, you're going to need intervention. But if you have an iliac lesion and you treat it, that can stay open for 2 to 5 years without a reintervention, and it's lower risk, it's less costly than treating below the groin area, and the benefit is massive because sometimes the inflow to your entire leg is a 2 mm lumen, and you get it to like a 7 mm lumen, and that can take care of the symptoms, and you can avoid treating the other disease for longer.
Kim, one of the things that's been interesting for me to work with Dr. El Serghany is where I previously practiced, everybody got a CT angiogram and also in Anchorage before they came to see us. But where we practice in Hawaii, we don't have that availability to do diagnostic CT angiograms just like that. There's no competition for radiologists. Oh, well, I've got this machine and I've got that and I've got a fancier this and it's quite the opposite. And so in his practice, we go in from the wrist and then come down. It's a much lower risk procedure. And then we get a nice mapping of the blood vessels going down both legs. And it can guide our approach that way. So I think some of it's regional in terms of the availability of resources. And it's a style difference. It's been really fun for me to come into his practice and see his style difference, because some of those approaches thought of because of the areas that I practiced, we had different resources, and people came in with very elaborate ultrasounds, or they came in with very elaborate CAT scans that were very accurate. And there didn't seem to be a reason to do a diagnostic study. But if you're in the middle of nowhere, you end up doing diagnostic studies because that's the quickest way to get the answers to what the actual anatomy is.
But even with the CTA, there's a limitation in terms of especially BTK and also the angle of it, right?
For sure.
So it's so funny. Even with those situations, I've had patients with symptoms, and the doctor's like, "Oh, you're fine. CTA shows this," and then you go in with IVUS, and there's a whole other story, and it's crazy.
That's certainly true, and that's also technique driven. So that if you have poor flow down one leg and good flow down the other, the tech also often doesn't understand the differentiation in the rates of blood flow down the leg. So you miss disease from one leg to the other. And particularly below the knee disease, it's hard to see it on CT angiogram.
And just a couple more questions before we get to our just final fun questions that we have that we use for educational segments. But I do want to mention that our friend Douglas here, when he first came to us, he ended up with a CT angiogram at a large university hospital. And the doctor never bothered to actually look at the imaging himself. Actually, it was the technologist that said everything looks great. And yet Douglas could not walk at all. And we sent him to a different doctor who I'm sure you're familiar with, Dr. Craig Walker. And when Douglas finally got there, it was a poor guy, 4-hour drive, poor Douglas, sent him 4 hours away because no one was taking care of him where he was. And he gets in the parking lot and he collapses. And they had to bring a wheelchair out there and get him in. And Dr. Walker, I will always remember this, called me as they were prepping Douglas. And he says, Kim, that guy was dead man walking. Thank you. He had no blood flow. And I said, well, how is that possible? The CTA showed fine. He said it was just collaterals. His inferior mesenteric had literally made up for everything. And that was all that was literally flowing into his legs, which to me is just crazy. How could a doctor at a large university hospital miss this? So
Examine the patients themselves.
Yeah. Okay. So before we get to the final questions for both of you, this is a whole different experience. Based on your experience, give patients your best advice on choosing a PAD doctor. What criteria would you use? And I know, Dr. Lurie, keeping in mind Dr. El Serghany, what criteria did you use to choose your doctor? And don't just say aggressive, like, what does that mean? So it's in wording that patients can actually understand.
We have this discussion pretty commonly about whether to use medical language and jargon to describe problems to patients, or whether to use normal day-to-day language. I think for me, the criteria for choosing the person who's going to do my procedure is their personal experience. We know, and this is data-based, that the best predictor of good outcome is doing lots and lots of cases. And so it's not particularly age-related because people can be young and do lots of cases. But I think total case volume of doing the types of cases that I need to have done is used as a major criteria for choosing a physician.
And Dr. El Serghany?
Yeah, I mean, that's a very safe answer, Dr. Larry. I mean, that's a safe bet because that is data-driven. I mean, that's how our training, that's why I chose to train in like a county facility where from day one you were going to operate, they needed help. So I always sought volume in training, and yeah, it's true. Volume breeds good outcomes, and you sort of see problems and patterns, and you can avoid trouble. And so volume's definitely one of them. The other thing I would say is having good chemistry with the doctor. You know, it's okay to like have a friendly doctor who can have a chat with you and communicate that you feel good about sharing your symptoms with, and can even push back a little on, because that communication part is really important, especially before the procedure. Setting the expectations and just letting the doctor know, you know, what you're really there for. So yeah, definitely, if you find someone that has volume, that's always going to be a safe approach. And I think it is important that you can have good chemistry with the doctor as well. And it's not offensive. Like I get patients that say, I just didn't like that doctor, so I wanted to come and talk to someone else. And it's funny how much you hear that story. And but that's the patient experience, right? You don't see the inside of your vessels. You don't really know what's going on. You just know your symptoms. And if you're lucky, someone will draw you a picture, or you can see an image or whatever, kind of put it together. But that's the other half of it, I would say, is making sure you have good chemistry with the doctor.
Okay, you both can comment on how I guide patients, and you can be completely candid. But, you know, number one, I always say, especially for intermittent claudicants and for lifestyle limiting claudicants, that you want a doctor that is not going to jump right into a procedure without saying, hey, what's going on here? Why do you have PAD? And let's make sure we're mitigating those risk factors. And they exhaust blood work, make sure that you understand what it means to walk, how to grow your collateral vessels, what medicines maximizing or optimizing, medication therapy. Let's determine what type of plaque you may have. Is it more atherosclerotic, or is it clot based? Do you have a lot of clots that are forming in your body? Do you have valvular issues in your heart? Do you have AFib? Do you have an aortic aneurysm? For smokers, maybe there's an undiagnosed cancer, but at least having the conversation about the risk factors and mitigating those risk factors, prior to going into any procedure. We definitely love anyone in that level to have access to a walking program if they can, supervised exercise therapy, structured, or at least giving the patient some guidance on how to walk and how many days they should walk a week, and then a follow-up appointment to see if those collateral vessels are actually working for them. And then when it comes to the procedure, and I always say it's good to have a doctor that can treat you at all levels of disease, or at least be prepared for the long term, just in case your disease does progress. And when it comes to a doctor that will treat a patient using the tools and techniques that are available to revascularize, I say first and foremost, make sure that you do have a doctor that can not only perform an antegrade approach, meaning coming down from the groin, but also if they can't get through a blockage heading south, that they do have the ability and the willingness to at least try a retrograde approach coming up from below through the foot, through the calf. I even have seen a couple of doctors recently go through between the big toe and the middle toe. I had no idea that was even possible. Probably rare cases, but at least they're trying to exhaust all efforts in a safe way, right? You do no harm. When amputation is on the line, at least exhaust all efforts to try and save that limb. And even prior to bypass, we always say, hey, make sure they've tried coming down from the top and up from below to ensure that they've exhausted endovascular methods and have a landing zone in case there is a bypass that's necessary. And then secondarily, that if they do fail at endovascular, that they do have the ability to perform a surgical procedure themselves, a bypass or endarterectomy still being gold standard in the bendy spot in the common femoral, or they can refer you out to someone that you can trust that does have great outcomes. But that's usually my spiel. Any comments?
Wow, you said it so well, Kim. Honestly, you hit all the points.
Really?
Yeah,
Really?
and that's exactly right. You want a physician who's going to kind of take a look at the whole picture, try walking exercise. We have a lot of PAs and NPs, like physician extenders in our practice. So they can take good time with the patient and discuss it for a good 20 minutes, like this is what we need to do. And we know the data says quit smoking and keep walking. Those are the two. I mean, forget about all the medicines and everything else. Those are the two main things that you can do to get out of that problem. And there are patients that can sort of walk their way out of the problem. Because as soon as you go into a category of interventions, then we're going to be friends for life. I mean, I'm going to see you every 6 months to 2 years. Sometimes you can strengthen a collateral to where you don't need the main vessel open. And that's a huge win for our PAD patients. If they can walk enough and that collateral flow, the anatomy allows for it, they can, and we keep opening the artery in the thigh, we keep having to reopen it, but the deep artery gets strong enough that they don't have pain even though the main artery is blocked, then they can get out of the problem that way too. So yeah, I mean, it's a comprehensive approach, and we don't just talk about atherosclerosis, we talk about the patient's lifestyle and even how they're doing socially, how they're feeling. Sometimes that plays a role. I had a patient come in who had basically his toe was getting black, the big toe, and he was sort of sullen and down and not very engaged, and he was smoking and things weren't going well. We got blood flow, we were able to save the leg, and it was a huge deal when he was able to wear his old shoes again, and he was kind of sitting upright, more engaged, more social, just happier. This disease takes a toll in ways that we don't talk about.
Yeah, 100%.
That's absolutely true. It's depressing. If you can't do what you want to be able to do, you feel like it's the end of your life. And people come in and say, you know, I'm dying, or I feel like I can't do things anymore. And you get them back to being active, and it really brings them back. It really is. It's really wonderful to watch.
Your thoughts? Did I hit the nail on the head in the criteria?
Yeah, I think I'm.
Did we describe you?
I'm not totally agree with you in some of the nuances, but yes, I think I don't think everybody can do retrograde approach, and I think if they can't do it, they shouldn't be trying, because
they shouldn't be trying, but you got to find a doctor who can.
Right, but it's hard.
Necessary for you,
and it's hard to find people who can do that.
I
In
know.
a practice, we turned people over and went up popliteal from behind their knee. That's always been a really nice approach for me.
Yeah.
And I like that a lot. But it's been really fun for me to do a lot more of the foot approaches with Dr. El Serghany.
Yeah, definitely. And you can't always find it, but we have to find the best in your area. And if you are willing to fly, or you're willing to drive, and you do have that ability, great. But we can always find someone that can at least exhaust all their efforts in the area to get them at least walking, so we can get them in our walking program and build those collateral vessels and
well,
such.
You're a phenomenal resource. So if people are listening and don't have this doctor in their area, they can contact you and you'll connect people.
We do connect people. Yeah. And we also help them if they just don't have those resources, a doctor that has the advanced skills. There are areas that just don't, and they have no ability. We work with them on a daily basis to do the exercises to grow those collateral vessels and get their diet optimized, and smoking cessation, and all that jazz. But our final questions, speaking of the lifestyle modifications, right? We ever go with the Flow series. So give us your best walking is medicine speech, or share the story of a patient that walked, their way out of a limb-threatening situation. But be descriptive, because it airs as its own separate segment. We'll start with you, Dr. Lurie.
I think up here people have unusual lifestyles. So I had a fellow come into my office, and he said his story was that he had several dogs. A lot of people have dogs up here, and they mush and do the things that you see on television.
Yeah, in Alaska.
And so he walked his dogs up to the mailbox, which turned out to be a quarter of a mile away. And then he progressively lost his ability to walk, and he was aware of that, but his dogs still needed exercise. So he would walk laps around his cabin, and so that he could always hold on to the cabin if his legs got weak. And he would just walk 15 or 20 laps around the cabin slowly to get his dogs out walking. And after we fixed him, he came back to the office and said, "How you doing?" He said, "I'm getting the mail now. I can go back to the mailbox." And that was his victory, that he didn't have to walk around the house anymore, but that he could walk the dogs to the mailbox. So I think that's a beautiful story. I think that's what we do. We get people back to their lifestyle, to their baseline. Yeah.
But it's good that he didn't let dust settle beneath him. He found a way to get out and move. And that is the important part.
All of it's true.
Dr. El Serghany, your turn.
Yeah, I would just share a story that sort of surprised me, and I just saw the patient again recently. But about 5 or 6 years ago, I was walking into clinic, and there was someone outside on the bench waiting to be seen. He was there early. And he had all the features of a patient with vascular disease. He was a smoker, and his leg he had dependent rubor. It was red. When you lower the leg, even the skin tries to get more perfusion down there, so you get redness in the skin. He came in, we took a look at him, and he couldn't move his foot. And it had been a couple of days. And the classic teaching is, if the blood supply, this happens more with acute limb ischemia, where a clot goes down the leg, and then all of a sudden the nerves are the things that suffer the most. So even if you restore blood flow, the nerve has already died, and then you end up with a drop foot, And the patient says, please just amputate my leg because I can't use it. So the teaching is we have 6 to 12 hours to get that vessel open, get blood flow, and reperfuse the nerve, the most sensitive thing to ischemia. But he hadn't moved his foot in 2 days. And sometimes you just tell the patient, well, sorry, it's dangerous to even go and open the vessel, because now if you open it, the tissue that's dead is going to get reperfused. You're going to circulate all these toxins. Let's just go and amputate the leg because you can't move it anymore. And that's almost like a textbook answer. But when we looked at his anatomy, his common femoral artery was occluded. So the main artery in the groin was completely blocked. It was blocking the deep artery and the native artery, the normal artery that goes down the thigh. And for some reason, I don't know, with him, I decided, this looks like chronic disease. Let's do an endarterectomy. So we removed all the plaque. We restored blood flow to his leg. And his nerves actually recovered. So I was shocked, and it just taught me that, even after I've been in practice for several years, you can't predict what's going to happen sometimes. And sometimes you just got to give it a shot and just go through the motions and treat a patient without preconceived notions. And you can even surprise yourself sometimes. And I just saw him recently. This was 5 years ago. I saw him last week, and, both his legs are still on. He's doing fine. He has other medical issues. But he got out of that problem without an amputation and without even a limp. Like, his legs were fine after that. So it just, that was a wake-up call to me to say, hey, you don't always know. Sometimes you got to try and give it your best shot. And even if you have some experience, there are still things to learn.
I love it. So we have a good lesson one. What about walking as medicine?
Walking as medicine. I mean, yeah, I have patients. One of my brother's neighbor, they met in the community pool, and he was walking up and down in the pool and doing his thing. And he's a captain, so he likes to go fishing, and he just couldn't go fishing anymore. So we asked him, like, what are you doing in the pool? Your exercise? Like, oh, my legs are killing me. My doctor's kind of writing it off, and said, well, why don't you come see us in the clinic? And yeah, he's captain. So we went and treated his disease. He had multi-level disease and the iliacs and the SFA. Once we treated the iliac disease, he was able to walk more and kind of walk out of it. So we're able to avoid doing further work. And now he goes fishing. He brings me fresh ahi, puts it in my freezer. He's also kind of a car guy. So one day he grabbed my truck. He took it into town, fixed it, and got it cleaned up, changed the battery leads. And I was like, well, Captain, why are you doing all, that's way too kind. And he said, well, I'm retired. I'm happy to do this. You help take care of my legs. And he knows how busy we are. It's hard for us to get out and do regular things like that. So yeah, I mean, it made a huge difference for him. And, I'm just happy he's out fishing again, so I can get some of that fresh ahi out here.
It's amazing, once that blood flow, how the legs can really affect your life in more ways than one. So, and Kevin, one last thing, Dr. Lurie, your greatest lesson that you've ever had that others could learn from?
My greatest lesson.
The case that offered you the greatest lesson.
I think
could have been your own.
I think I'm old school, and so we don't examine patients like we're supposed to, right? We see people, and you say to the patient, so did they examine you? Oh no, I didn't take my clothes off. Did you take your socks and shoes off? No. We just talk to the doctor, and then you get the printout from them, and it has a whole 45-minute physical exam, like they looked in their eyes and their ears and their heart, and none of it's done. And I think that examining patients is probably the most underrated thing that we do. So when I cover, for instance, for Dr. El Serghany, I go in and I hands-on, make sure I can feel people's feet, see their toes with my eyes. Do they actually have pulses in their wrists? Do they have pulses in their groins? Do they have pulses? So that I can get a physical sense of what their circulation is like, and know how to move forward.
Touch the patient, touch the patient, touch the patient. So important. important. Thank you so much to both of you for being here, extending, God, so much time on your Saturday. We really appreciate it. Such an incredible educational experience for so many patients, thousands across the globe. If anyone has any more questions for Dr. Lurie or Dr. El Serghany, if you're in Alaska or you're in Hawaii, make sure to call our Leg Saver hotline at 1-833-PAD-LEGS. We're happy to get you in touch with their team. If you have questions about PAD or any other vascular issue, I'm sure they would be more than happy to see you and have the conversation. But before you all leave, make sure you like our video, subscribe to our channel, the @ The Way to My Heart. It's great for our algorithm to help spreading awareness for PAD. But thanks everyone for joining us, and we'll see you next time.
I got a quick one for Dr. Lurie if he's got. Were you glass blowing before,
Good
or
timing, Douglas.
have you been doing that? You're
I've been
glass
blowing
blowing.
glass. I've been blowing glass my whole life.
Have you?
Yeah, but I built a studio here in August. Yeah, so I have a hot shop here, and so I started in my shop in August. Otherwise, I work, but I've been blowing glass since I was in my 20s. Yeah.
That's awesome. So getting your legs fixed has been a big inspiration, hasn't it?
It's just been great for me to get outside and do more and be much more confident in the activities that I do. I lead hikes up here probably once every 2 weeks, and some of the hikes are quite tough. And so I used to say to people, you know, when at this part over here, it's a little steeper. You guys go ahead of me. I'll get there, but I'm just slower. And I was up last week and I said, oh my gosh, I'm the first one up. Well, look at that. I was so happy to be the first one up on that hike because I'm not used to that. And so it's been really wonderful for me to be able to get up there and do more and be at the front of the pack. It's been really nice.
And that's what Kim and I
don't know
talk
if you
about.
can see that. Well, I don't know if you can see.
Oh, there you go.
There we go.
Look at that.
We need to get him hooked up with BJ.
Right. I mean,
we have another great hiker, PAD. She walked her way out of CLI and up a mountain.
Yep. Absolutely. So it's been really wonderful.
And I think that's why I wanted to ask you that, because we find it hard to get people to keep their inspiration, their hope, and their courage up, no matter what they're going through, to keep going and to keep walking and to be hopeful that we can get through this. We will get through this. I mean, I'm sitting in my house now that I built by hand. So, and I've done this the last 5 years with everything I've been through. And we got Thomas here is going through it. And it's hard to keep people engaged. And like you said earlier, I could walk halfway to the mailbox today, but if I take that next 2 steps, next week I'm going to walk to the mailbox.
Exactly. Yep. Count your steps. And count the steps and do more of them. Absolutely.
Yeah. Give us that best motivational speech, Dr. Lurie.
I think it's about having a structure in your program and saying, okay, you know, I can sit on the couch and I can watch one more television show that I've already have seen 30 times, or I can get out and just count your steps. Just go out and do 100 steps out and 100 steps back, and then watch the rest of the show. But just keep doing it, and you'll get to 110 and 150. And it's really remarkable how your body will heal it. Yeah.
And Douglas opened up a can of worms here really quickly. We do have a YouTube question coming in from old bikers. So why don't we unblock the main artery instead of all of this suffering through? Why don't we just open up the vessels that are narrowed? Why don't we just open up the vessels that are blocked?
It's called, I mean, we call it starting the clock, because once you start treating that vessel, all we're doing is pushing the plaque aside. And the body responds. It's almost like an injury, cracking the artery open. So the body responds by that area will get narrow again in 6 months to 2 years. So if you can strengthen the collateral, the body's natural bypass system, and heal it that way, that will stay open. Whereas the intervention that we do is limited. Most of the time, within 6 months or 2 years, we got to go in and touch it with a balloon. And it's, you know, it's not a very high risk procedure. It's another angiogram. But then there are limits to how often we can do that, and other areas pick up disease as well. So the lifestyle changes and strengthening your own, the body wants to heal itself. Strengthening your own collateral system is more important than what we do, than our part.
The fact that we do have this collateral system just goes to show the body's ready to adapt. And all you got to do, you got to walk, push through and build up that system. Thanks so much, you guys, again, for joining us. Again, subscribe to our channel. You got an extra bonus set of time here. So like the video, subscribe to our channel, and thanks you guys for the extra time for joining us.
Yeah, you've done a great job.
Thank you.